Hello and welcome to the CNDA's Naturopathic Webinar Series. We are pleased that you have joined us for the CNDA's 6th Naturopathic Webinar on topics in integrative gastroenterology. We hope you find this webinar series to be a great, convenient, and educational means of obtaining your continuing education hours. Our topic this evening is on small intestinal bacterial overgrowth, integrative approaches to healing dysmotility, dysbiosis, and malabsorption with Dr. Adam Rinde. My name is Dr. Debbie Walker, and joining me as organizers for this webinar are CNDA's Executive Director Larry Cook, Dr. Anne-Marie Nguyen, and the CNDA's Events Coordinator Karen Brzezinski. For those of you new to the webinar format, I would like to orient you to what you will be seeing on your screen. This presentation will be viewed in a PowerPoint format. There is a toolbar on your screen that you can maximize and use to type in your clinical questions for the speaker. There will be 2 10-minute question and answer periods during the presentation. You can type in your questions at any time during the presentation, and we will read them in the order received during the Q&A sessions. You may minimize this box until needed. You can also use this box to communicate with our organizers if you are having any technical difficulties. If you continue to have technical problems, you can call our webinar technical support at 1-800-263-6317. Please be aware that the GoToWebinar system monitors and reports attendees' sign-in and sign-out times. This means that you need to stay on the webinar screen for the entire duration of the webinar to get full credit. You will receive an email tomorrow with a link to our online survey. Your CE certificate will be ready to print immediately upon completing this online survey. Please note you will need to complete the survey in order to receive your certificate. This is a 2-hour presentation discussing small intestinal bacterial overgrowth. Now I'd like to introduce our presenter, Dr. Adam Rinde. Dr. Adam Rinde is a licensed naturopathic physician with a special interest in enteroimmunology, the relationship between gut-mind, immune, and endocrine systems. His awareness of small intestinal bacterial overgrowth stemmed from a complex case of IBS, which he treated for SIBO, which resolved in a dramatic fashion. This sparked the desire to learn, apply, and refine approaches to functional gastrointestinal disease. He is a 2006 graduate of Bastyr University and also completed his residency at the Bastyr Center for Natural Health, where he continued as an adjunct clinical faculty from 2007 through 2011. He is currently the owner and physician at his private practice called Sound Integrative Health in Kirkland, Washington, which he has operated since 2007. He's a member of the AANP, the WAMP, and the Institute of Functional Medicine. We are truly grateful to have him with us tonight. With that, on behalf of the CNDA, it is our honor to present to you Dr. Adam Rinde. Dr. Rinde, you may begin your presentation.
Thank you for that warm introduction, Dr. Walker. Today, as we've discussed, we're going to be discussing small intestinal bacterial overgrowth. I first want to thank the CNDA for inviting me to speak. This is a very interesting topic for me. Here is the schedule for tonight's talk. I'm basically going to be walking you through the process of understanding SIBO from the background all the way through treatment and case management. It's a monumental task to cover this in just a few hours, and I'm hoping that at the end of the night you'll walk away with a deeper understanding of this topic and confidence on workup and assessment and the ability to begin to walk your patients through this process of treating bacterial overgrowth. I realize that many of you have been doing this for a long time. I think we now have a name to call something that we've been treating for a very long time. Naturopathic physicians have long understood the concept of treating the gut and issues related to dysbiosis. This is just going to sharpen our approach and make it more personalized. So here is a slide that just kind of covers some of the central issues in bacterial overgrowth. Are we dealing with the chicken or the egg? SIBO a actual treatable condition, or is it a symptom of another process? And what are we actually treating? Bacteria, archaea, fungi? Is when a patient tests positive for SIBO, is it actually SIBO that's causing the problem? Because SIBO, as we know and we'll learn, can mimic a number of different conditions. So other issues that I'll be covering is the fact that there's a high relapse rate in treating bacterial overgrowth, and we have a very loose standard of care, and there's a high refractory rate to treatment. So here is the newest, most updated definition. So bacterial overgrowth is essentially a situation or process where enteric gut bacteria has reached areas of the GI tract in excessive amounts. More specifically, it has reached the sterile small intestine and set up home. We all know that gut bacteria in the colon have a usually symbiotic relationship with the host. However, in SIBO, this gut bacteria is out of place and contributes to a disruption of normal digestive and inflammatory process in the small intestine. There's another subset of in the literature called short bowel syndrome, and this is actually changes in the length of the short bowel due to various processes, either surgery or inflammatory bowel diseases, trauma, etc., that has resulted in making the small intestine closer in proximity to the large intestine and increasing the exposure of the small intestine to the bacteria in the colon. This is not the main focus of our topic, but it's important to know that when you're dealing with bacterial overgrowth, short bowel syndrome sort of is an overlap in the terminology. So as we mentioned earlier, the small intestine is relatively sterile as it's compared to the large intestine. And that is mainly because of peristalsis and also the pH balance that's in the stomach in the duodenum. These processes keep the flora relatively low in these areas of the intestine, and that magnitude of bacteria increases once you cross the cecum, cross the ileocecal valve, and move into the proximal colon. So this is an important slide to hone in on. These are the main microbes we're dealing with in small intestinal bacterial overgrowth. On the left, we have methanogens. Methanogens are actually from the kingdom of archaea, which is a kingdom of single-celled microorganisms. These microbes are prokaryotes, meaning they have no cell nucleus or any other membrane organelles in their cells. So these particular organisms produce methane gas and are associated with constipation. The main organism that's been identified in this is Methanobrevibacter smithii. We do test for methane production and bacterial overgrowth, and it's highly associated with constipation. On the right are hydrogen-producing bacteria. So this is the most commonly found bacteria in bacterial overgrowth. It's more associated with diarrhea and will produce positive hydrogen production on the lactulose or glucose breath test. In the middle is the newest of the identified bacteria that may be involved with SIBO, and this is hydrogen sulfide producers. Hydrogen sulfide producers are currently not identifiable on a breath test. There are some tests I've seen show up that have been shown in the United Kingdom that are being developed, but currently we don't have a way to detect it. Mainly in some of your patients, you'll find that they appear to have bacterial overgrowth. However, their lactulose breath test is negative for for hydrogen or methane. It's called a flat line. And this particular population may clinically be patients who have hydrogen sulfide overgrowth. The only thing I can say that will give away a possible history clue that the patient may have overgrowth of hydrogen sulfide is they'll complain of sulfur or egg-smelling flatulence. Now this particular subset is being linked to gut permeability issues, chronic fatigue syndrome, and fibromyalgia. A lot of work is going to be going into this subset in the future, and it may broaden our way to help patients. So this is a slide of what's going on in bacterial overgrowth. On the top side is a normal cross-section of the small intestine. On the bottom slide is what we see taking place in bacterial overgrowth, the bottom section. So, for example, what you're seeing is the gas production illustrated by the cloud gas production here is taking place further up in the intestine than normal. Normally, gas will be produced in the ileum, in the distal part of the ileum in the colon, and be released through the rectum. In small intestinal bacterial overgrowth, this gas is being produced excessively because of host bacteria living in this region that start to digest certain carbohydrates, and gas is produced excessively and somewhat trapped in this area, causing distension and bloating. So normally, things that keep the small intestine sterile are listed here. These are innate physiologic processes that will keep bacteria from overgrowing in the small intestine. So good forward directional digestion, peristalsis, serum IgA, and adequate gastric pH. I'm going to highlight on this list the migrating motor reflex, because this is an important aspect of treating bacterial overgrowth. So let's talk about normal motility. There's two main subsets to focus on in the motility process. One is segmentation, which occurs with peristalsis, and the other is the interdigestive period. The interdigestive period occurs in the fasting state, and it occurs between meals every 1.5 to 2 hours. So in this particular state, the intestine goes through a wave, which is called a cleansing wave, which is a house cleaning of the lumen. Undigested particles and bacteria are flushed out of the small intestine. It's a normal physiologic process. It's disrupted by fasting. As we'll see, that there is a problem in this process and in the bacterial overgrowth, in small intestinal bacterial overgrowth, and it's an underlying therapeutic target. So there are various ways that the migrating motor complex is impacted. There is various innate physiologic hormones such as serotonin and ghrelin and somatostatin that will regulate the migrating motor complex. In small intestinal bacterial overgrowth, we see a disordered pattern in migrating motor complex activity. So what that means is the cleansing wave is disrupted, disordered, and undigested particles and bacteria do not get flushed out of the small intestine as well as in a finely regulated migrating motor complex. On this list, you'll see erythromycin, which is a medication that's being used in bacterial overgrowth to promote good regulation of the migrating motor complex. And you'll also see serotonin, which may get some of you thinking about ways to tonify the migrating motor complex. So alterations in the migrating motor complex shows up in a number of disease processes. We see it in diabetes leading to gastroparesis, and in functional dyspepsia, also in anorexia. So underlying the migrating motor complex is the interstitial cells of Cajal, also known as ICC cells. So this tells us a little bit about how the migrating motor complex may get damaged. Many think it's due to damage or attack or dysfunction of these interstitial cells of Cajal that disrupt the migrating motor complex. These interstitial cells of Cajal are considered the pacemaker of the gut, which regulate many of the gut's motility processes. The interstitial cells of Cajal relay electrical signals and communicate with a network of smooth muscle fibers and nervous tissue to regulate the migrating motor complex. So this is very important to learn, is that one of the proteins that the interstitial cells of Cajal rely on to communicate is called vinculin, which is a protein that supposedly brings these interstitial cells of Cajal together to create an electrical signal to help with motility. We'll talk about in a little bit how vinculin damage may be the underpinning that sets this process off of damaging the migrating motor complex. I hope this interests you as much as it interests me when I learned about this recently. So this next slide I put in the presentation because this is a hot topic, which is gut permeability. And we think that this may be taking place in bacterial overgrowth. This slide was based on biopsies of 67 patients with SIBO. And 48% of the patients with SIBO showed some histologic abnormalities compared to 36% of the control. What was impressive to learn on this was 24% of the SIBO patients had a villi to crypt ratio less than 3:1, and in control it was only 7%, meaning that there's some flattening of the villi taking place in bacterial overgrowth. And there also was indication that there is an immunoinfiltration of the villi, and so it's clear that potentially there's a real quantifiable pathological damage taking place that will validate the theories of leaky gut syndrome. So this book I'm putting in here just to give you a reference. Sort of the first hypothesis back in 2006 that linked SIBO to IBS was through Dr. Pimentel at Cedars-Sinai Hospital. This book is still a good reference, but as you'll see, they've updated their hypothesis quite a bit. So that brings me to this slide here that talks about what now is coming out of Cedars-Sinai Hospital as being an autoimmune theory of irritable bowel syndrome. I'm going to walk you through this process. This was talked about this July at the Global IBS Symposium. And now there's evidence to think that IBS is actually an autoimmune process. And here's what was gone through at the seminar. So we think that in IBS that 20% of patients with some form of acute gastroenteritis will go on to develop IBS. So gastroenteritis, also known as traveler's diarrhea. And many of those patients will also develop SIBO. And here's how they're proposing this happens. So in acute gastroenteritis, there's a very descriptive toxin released by common organisms like Campylobacteria, E. coli, Salmonella, and Shigella. And they all produce a toxin called CDT, or cytolethal distending toxin. I mentioned vinculin earlier, and supposedly these toxins lead to damage in the intestinal wall, which cause a production of anti-Feculent antibodies. So these antibodies form an attack on vinculin, which helps the interstitial cells of Cajal relay signals to regulate the migrating motor complex. So over this process, the gut motility and the migrating motor complex is damaged, and they're proposing that IBS with SIBO develops over that time and then persists. This process takes about 3 months and maybe more, and some of your patients may not remember getting acute gastroenteritis and develop IBS or SIBO sometime thereafter. In the next 6 months, a blood test will supposedly be developed, and it will give us the ability to measure anti-vinculin antibodies. And this will help us rapidly determine IBS compared to IBD and help us have a diagnostic blood test for IBS. And as you can imagine, the therapeutic approach to IBS and an underlying bacterial overgrowth as an autoimmune condition may be drastically different than we treat it today. So this is not my speculation. The references are on the bottom of the slides and references throughout the slides on things that I'm stating. This is directly from Dr. Pimentel's group. So this is just more of a synthesis of what I spoke about earlier, the process of bacterial overgrowth developing. So it's really important to realize that in all of our patients that we deal with, or at least the great majority, that there is a mind-gut component. It's not the nature of this talk. It is an area of great interest to all of us who treat digestive disorders. And we do know that there is a link between the terrain of the brain and hormonal releases related to stress and depression and anxiety and problems in the gut. So in all these patients that we're talking about today, this is something that we would always want to weigh into our workup, is the impact of the mind-gut balance. So if you follow the literature on bacterial overgrowth, you'll find that there is quite a expansive list of where bacterial overgrowth shows up. I've broken them down into some categories. In some conditions, it seems to be downstream sequelae of extraintestinal pathophysiologic processes. For example, the neuron problems in Parkinson's disease leading to disrupted motility in the gut, which may result in SIBO. Or neuropathic changes in type 2 diabetes contributing to gastroparesis, also leading to SIBO. Or, as we can see in some of the conditions, an innate digestive pathophysiologic process like Crohn's disease may lead to SIBO due to structural changes, strictures that may provide blind loops or pockets for bacteria to grow. So again, we're looking at this, and it looks like SIBO is a downstream symptom in many of these patient populations. But it is something still to deal with, even if in some of these patients it's a palliative treatment, because patients tend to feel better, as the data is showing in conditions like Parkinson's disease when we do eradicate the bacterial overgrowth. So this is another slide showing some of the contributing factors to SIBO. Even iatrogenic causes like proton pump inhibitors can lead to SIBO. And I'm beginning to look at SIBO as more of potentially a symptom. That's a symptom that we're treating of a bigger process. So here's some other risk factors for bacterial overgrowth. We'll be talking about FODMAP intolerances in just a little bit. Also, opioid use, which is constipating, may lead to bacterial overgrowth, PPI use as mentioned, and some of the low innate protective qualities of the gut. So let's look at what a patient actually appears like when they come into your office with the possibility of having small intestinal bacterial overgrowth. So many of the symptoms of SIBO are nondescript. In an outpatient setting, depending on the age and gender, you would think that the SIBO patient looks a lot like potentially IBS, celiac disease, maybe food intolerances, Crohn's disease, colitis, or chronic pancreatitis. Many of these patients that come in your door will fit Rome 3 criteria for IBS. But there are a few things that seem to give away the SIBO patient, at least in my practice. One is these core symptoms. So the core symptoms of bloating and distension that's worse after meals. And this is really key, is that it seems to reset overnight. So I'll ask these patients, so the bloating, does it go away? Is it gone when you wake up in the morning? It's a really good clue for me that there's some type of dysbiosis and bloating that's due to disrupted motility. So most of these patients will have some type of chronic constipation or diarrhea, some irregular bowel patterns. And most of them will have abdominal discomfort and generalized pain. It's usually not real intense pain. That would be more of a red flag. Oh, and it usually is not more of a specific pain. It's more generalized. So bloating and distension are two different things. Bloating is more of a sensation of pressure. Distension is actually a more measurable appearance of the gut, where it's actually increased abdominal girth. Both of these can be present in this population due to various different reasons, but distension is usually associated with visceral hypersensitivity, and bloating is usually associated with increased gas or pressure in the lumen of the small intestine. Objective physical findings are rare in our population of patients. In real severe cases of SIBO, we'll see some of these other findings like B12 deficiency, hypocalcemia, and cachexia due to malnutrition, but not often. In fact, a lot of your patients, the only thing you may get on physical exam is some general abdominal discomfort. Regarding on physical exam, there's not a whole lot of clues. I will say that if some of the patients develop skin conditions like dermatitis due to nutrient deficiencies or malabsorption, and I've seen a lot of patients with bacterial overgrowth have rosacea. So here's your differential in bacterial overgrowth, small intestinal bacterial overgrowth. It can look like a lot of non-concerning things, and you can also include a lot of more serious disorders. So these are other digestive disorders that might appear that you want to think about when you're working up someone for SIBO. So the biggest two that we think about a lot are Crohn's and colitis and celiac disease. Also, I would put on this list the microscopic colitis, which is now being somewhat included in the IBD world in that category. And something I will talk about a little bit later, there's actually a new term, believe it or not, for enteric candidiasis called SIFO, small intestinal fungal overgrowth. Obviously, we know, and you know from treating people with digestive disorders, that that should be included in the differential. And other autoimmune conditions that may affect gut motility, like hypothyroidism, ovarian cancer, because one of the hallmarks of ovarian cancer is bloating, so it would be unlikely to wax and wane, however. Big one, colon cancer. I would say if the patient's having symptoms in the evening, or if there's any red flag symptoms like bleeding in the stool, and if they're in the demographic age range of potential colon cancer, you really want to make sure you're ruling that out before moving on. Nighttime digestive symptoms are always sort of a red flag. So is SIFO the new enteric candidiasis? This is a really interesting study. It's actually a supplement to a publication that came out where they're starting to do duodenal aspirations of patients with bacterial overgrowth, and they're finding that a lot of patients have both SIFO, which has been identified as Candida, and SIBO simultaneously. So this is something to think about if you're stumbling along with a patient and they're not getting better on a SIBO treatment. Have you also considered treating them for fungal overgrowth? And one thing I would say from this particular study is that they point out that the patients with Candida presented more with nausea, and the patients with SIBO presented more with abdominal pain and gas. So that's one clue. Obviously, I think most of us would agree that we don't have a great test for determining Candida, because a lot of the stool tests are negative, especially if we're testing the small intestine. And it's not practical to do duodenal aspirates on patients. Okay, so we're now going to move into workup and testing. So there is not a very good blood test available for assessing for bacterial overgrowth. Even CBC showing macrocytosis, it may give you a clue, but it wouldn't be diagnostic of SIBO. Stool testing is more useful for monitoring treatment, in my experience, and not necessarily great for diagnosing. There's a few clues that it might tell you, but as far as a firm diagnostic tool, it's not that great. And imaging, we don't have any studies right now that would indicate SIBO. As we've talked about, the aspirate is invasive and more research-oriented. So it leaves us with the most practical test, which is hydrogen breath testing. I put in this slide, which is from the Rome 3 criteria website, where it gives you a really nice walkthrough algorithm of the patient with recurrent abdominal pain or discomfort. And this particular slide will help you avoid missing any red flags. It gives different stop points. For example, if you do see alarm features of blood in the stool, nighttime changes in bowel habits, weight loss, what to do next. So before you end up with looking at IBS, or as we will call this small intestinal bacterial overgrowth, falling in this kind of process, we'll have gone through and ruled out celiac disease, inflammatory bowel disease, microscopic colitis, based on the patient not presenting with certain identifiable red flags. So this is one way to approach the patient to make sure you're not missing any serious disorders. So on blood tests, the standard thing when you're working up SIBO is for sure to do a CBC, CMP, and a serum methylmalonic acid, and this is to look for any frank nutrient deficiencies. You can add on some other tests if you would like to help with substantiating some of the other therapies you might do, and also as a means of monitoring. The lactose mannitol test is used for gut permeability, as is the long list of the occludin and zonulin tests below, and the LPS tests listed below. These are all markers of gut permeability issues, and I would only add most of these tests on in really complex cases, because we do not seem to have good coverage, is one thing, and also I'm not sure how useful they are at this point, but I think as we learn more of bacterial overgrowth being a trigger for gut permeability, we may want to use these to help us determine the efficacy of treatment. Hopefully the patient's clinical process and how well they're doing on treatment will also give us clues as to how well we're healing the gut. Stool testing, there's no standard test for SIBO. Some of these other tests that are added in on this list may give us a sense of the overall digestive function. I always like the term 2-tack versus 1-tack. SIBO is generally not a 1-tack problem, meaning if you eradicate the SIBO, the bacterial overgrowth, it doesn't mean there's other issues in the gut going on that you still need to address. So sometimes, and again, the more complex patient may want to push to add on some of these tests. They're likely not covered by insurance. So that leads us to the standard testing that we do, lactulose hydrogen breath test, and then there's some alternatives listed here as well. So here's how lactulose breath testing is intended to work. So we have a patient swallow lactulose, and generally there is no lactulase enzyme in the small intestine to hydrolyze lactulose, which is a sugar. Therefore, it's usually transported intact to the colon, where it's metabolized by the colon bacteria. When bacteria come in contact with this lactulose, which is a disaccharide, they metabolize it and produce gas, such as methane or hydrogen. And this can be detected by assay or by the expired air. In healthy populations, the bacteria is generally down in the colon area, and therefore, after 2 hours, you'll get some gas production. However, with bacterial overgrowth, we'll see gas production before that time, so we know it's taking place higher up in the small intestine and in amounts that are significant to be determined bacterial overgrowth. There's another test called using glucose. All of glucose is absorbed in the duodenum, in the jejunum, and under normal physiologic situations, there should be no gas production. So on a glucose breath test, we'll see gas production in this area of the duodenum and jejunum, and that can potentially be a positive for bacterial overgrowth. So we'll talk about when to use a glucose breath test versus lactulose breath test in a moment. You can imagine that some patients using the glucose breath test may be better, and in others the lactulose breath test may be better. So these are different ways of going about treating or assessing for SIBO. There's the in-office breath analyzer. It's available in some labs in local areas and also in some GI offices. And then there's the home kits. And on both these tests, it's basically the same process. And the patient will be swallowing either lactulose or glucose after having fasted for 12 hours and adhering to a specific low residue diet. And we'll be taking samples every 20 minutes, and we track methane and hydrogen production. So realize your patient's going to be doing this for 3 hours, or be at a facility and be sitting down and doing this test for 3 hours. And so you may discuss with your patient which setting they prefer. So breath testing, there's a list of the CPT code that we use. The insurance coverage is hit and miss. I've seen full coverage and I've seen no coverage. So you best to call in advance and check. But I would prepare your patient that they may be stuck with a $250 bill or thereabouts for at least the home test. I'm not quite sure what the end result would be for a in-office test that wasn't reimbursed. So sensitivity and specificity of these tests. So now there's large studies that are looking at which of the two tests are more sensitive between glucose and lactulose. So lactulose seems to be the most sensitive. So it has less false negatives than glucose, but more false positives. And so that gives you some idea that you really want to match clinically the symptoms of the patient with the results to determine your diagnosis. And glucose, I'll mention in just a moment where it might be an appropriate test to order. This slide is just thrown in because I wanted to show you why bacterial overgrowth breath testing is still considered somewhat controversial. The study on the far right showed that actually in controls they were getting more bacterial overgrowth than in IBS. And then Dr. Pimentel's study in 2003 showed 84% bacterial overgrowth in IBS patients, but only 20% in controls. So there's really a wide range of opinions about this test. So it's not the best tool. And again, as good clinicians, sometimes we use a test to confirm a strong diagnostic workup that's been done through history and physical exam. So here's some information on how to interpret lactulose hydrogen breath tests. The standard is that an absolute increase in hydrogen by 20 parts per million above baseline within 90 minutes is considered a positive hydrogen lactulose breath test. So the hallmark of the pattern would be this really nice double peak scenario where the bacteria is overgrowing, and at the 7.5 minute mark, 7 sample, we see a spike, and then another spike. So this last spike indicates where the solution has reached the colon, and this spike here indicates that we're still in the small intestine. Normally that would not happen in a sterile small intestine. Also, methane, which is indicated by this pink bar across the bottom, if that is greater than or equal to 3 parts per million rise at any time during the breath test, then it's considered a positive for bacterial overgrowth, which is methane positive. Sometimes a merge pattern may appear from the bacterial overgrowth, so you'll see an early spike, but there's no 2 peaks. So you'll see one merge pattern. I think I have an example of that later. And that is sometimes a equivocal result where you may have to be making a decision on whether or not that is normal colon transit versus bacterial overgrowth. Again, another view of a positive test. And here's a view of a positive methane test. So quick break for a question for you all. I realize you won't have the ability to answer it yet, but be thinking, what subtype of bowel pattern would most likely test positive for methane? And the answer is the constipated subtype. So realize also that methane, to produce one methane molecule, it takes 4 hydrogens. So a lot of times you'll see a flat line of hydrogen and a positive of methane. So that's because the hydrogen is being used to produce methane. And it's not uncommon when you see both an elevation of hydrogen and methane. So again, just putting this slide in to point out more possible flaws in hydrogen breath test. This shows when you weigh in diversity of populations, we realize that diversity exists in colonic transit times. So the mouth to cecum transit time in this particular study showed that in Asian populations it was less than 90 minutes. And in healthy East Indian patients, it was 65 minutes. So most of these tests are based on 90 minutes being the norm. So we're really having to be individualized and specific to how we're using these results. And again, good history taking will help you determine whether the test can be equivocally determined as positive or negative. So this is just to reiterate what I just said. And I want to point out one thing. It's not uncommon where your constipation patient who you're convinced will be producing methane will not produce methane within the time of the test. Why is that? That is because the test is generally around 3 hours, and the transit time of these patients might be much longer. So you may get a flatline result, but they still may be methane positive. There may be a movement to increasing the test time to 4 or 5 hours, but again, that puts a big burden on the patient. So realize that you have to weigh in the results and determine whether an empirical trial is appropriate in some patients. So I'll point this out, this particular slide. This was mentioned at the IBS Global Symposium, that we may be detecting just the tip of the iceberg of these patients, because methane is only detected when quantities of the methanogens are 10 to the 6th power greater in the small intestine. So there's a group of possible methane-producing patients that, according to Dr. Quintron, may be undetectable with our current technology, but still may be relevant to treat. I don't know about you, but with my SIBO patients, I have much more of a challenge treating the constipated patient than the diarrhea patient, and we'll talk about that in a little bit. This just validates that methane producers are 3.5 times as likely to be functionally constipated. And we're about to start the Q&A section of the first segment of tonight's talk. And this just gives you some things to think about the positives, the false positives of the breath test. So lactose breath test has a higher rate of false positives, and the lactose breath test may be missing those patients with a rapid transit time. Really try not to lose you here. So because lactulose is normally digested further, we may be seeing that the patient, I'm going to flip back here. We may find that we get on a lactose breath test in a rapid transit patient, we may see one spike. That's because the lactose is actually getting to the colon and before it's able to be absorbed. So with a glucose breath test, since some of it is digested in the small intestine, most of it is digested in the duodenum. That might be more appropriate in some patients where you feel like the lactose breath test has led to a false negative. So these are some of the reasons why, ways that the breath test is thrown off. A false positive can result from rapid transit time, as I was just alluding to, failure to fast, failure basically to follow instructions. Not brushing your teeth can lead to an early spike and show fermentation. That's right before the test. Basically, the guidelines that are pointed out to the patients, but failure to follow those. And like I mentioned with methane production, you may not see methane production within the first 3 hours of the test. Also, if a patient's used antibiotics within a week, can lead to a false negative. Laxative use may also contribute to this. And SIBO confined to the ileum may show one continuous spike. So again, this will lead us to need to, in specific situations where the lab results are, where the breath results are not straightforward, it will lead us to have to make some individualized decisions. So I have basically consolidated this opinion already, and we'll move to question and answers.
Hi, Dr. Rindy, when you talk, you might talk a little bit closer to the mic as well.
Okay.
Okay, so for questions, the first question is, could HLA-B27 be one of the organisms that could trigger the autoimmune cascade for IBS, SIBO?
Okay, so HLB27, I'm not aware of it being involved in this process. What I am aware of is that the CDT toxin and its attack on the small intestine mounts an immune response that, according to the latest research, is causing the formation of antivinculin antibodies. HLA-B27, I'm not aware of that being connected there, but it is a major marker in autoimmune conditions, so it'll be interesting to see if it's tied in.
Okay. Do you ever treat SIBO without testing, just based on strong clinical findings?
That's a great question, and the answer is yes, I have, and it always makes me a little concerned when I do, but there are certain patients when I feel that had a really good exhaustive workup of various other possible causes and that they're fairly healthy and hardy enough to deal with any type of die-off effect, I have moved forward with treatments, and sometimes it really works out. It's always more reassuring to everybody when you have a little bit more data, though.
Okay. With that many factors causing false positives and false negatives, it seems like breath testing has little overall utility. Wouldn't it be better to just read, that kind of, yeah, what you were just talking about just now, about the false negatives and false positives and how accurate the breath test is?
Yeah, well, I think it's not a terrible test, meaning, it does have some validity in, the larger studies and some of the most dedicated researchers really support its use as a tool. We don't have anything better right now that we could do that's reasonable. We can't do jejunal aspirate. So, I mean, I think in any workup, it's a useful tool also to monitor response. So if you do get a positive and you repeat the test, if the patient responds clinically and you repeat the test and the gas has methane production or hydrogen production has now become undetectable, then you have confidence that your treatment process and the treatment direction you're going is likely to result in a longer-term response. So I do think it's a useful tool, but I understand what you're all saying. These are part of the struggle with the fact that it's not perfect.
Got it. And any insight into the possibility that a dysfunctional ileocecal valve could be responsible for SIBO because the flow of fecal matter is backing up from the cecum into the ileum?
Absolutely.
Any data on efficacy of treating the valve dysfunction as part of the treatment?
I think that's a really good comment. And yes, it's backed up that there's problems with ileocecal dysfunction leading to bacterial overgrowth. I think I mentioned that in one of the earlier slides. And if you know how to treat the ileocecal valve, as far as ileocecal valve dysfunction, I think including that as part of your treatment makes sense. I personally only know of a few things that hypothetically could treat the ileocecal valve dysfunction, but I'm interested to learn more.
Okay. Have you seen food allergy sensitivities resolve or improve with SIBO treatment?
Yeah, so that's jumping ahead a little bit to treatment. What we do know is in patients with FODMAP intolerances, they seem to start off their treatment with many intolerances to FODMAPs, and then as they respond to treatment, they may end up being only reactive to one or two groups. It seems that as the gut heals and as the inflammation and the bacterial overgrowth goes down, there's better absorption overall of food and less maldigestion. Since food intolerance is sort of possibly something that's an obstacle to cure for bacterial overgrowth, I think it's something that we have to include in our treatment approach, and I'll talk about that in just a little bit.
Okay, just a couple more questions. Have you found that different labs produce better results in terms of sensitivity and specificity? Is there a preferred lab that you use, especially for home kits? Yeah,
I think that's a great question, and I don't know if I can endorse a particular lab, but what I would say is that I like to rotate through the common ones that just so that I'm not aligned with one, and I sort of have confidence they basically use a similar technology. If there's a lab that's not using Quintron to analyze the tests, I really don't trust it as much just because lots of the data has used the Quintron technology. So Quintron's sort of the back end of whatever these companies are marketing, and they usually just put their name on the lab. So I find that I rotate through the various companies that use Quintron.
Okay, and then the last question is, have you heard of a well-known study that found no correlation between positive SIBO tests and IBS?
Yeah, I think I showed one earlier, one of the slides, where there was more SIBO in control subjects than in IBS. So yeah, they're out there. That's one of my struggles with the breath test is that there's these negative studies, and it just depends on sort of what data you tend to buy into. I think the numbers of the patients, if you look at the studies and see how many patients the numbers of the subjects in the studies should be one thing to look at. And I think there's a lot of smaller studies out there. I think some of the studies coming out of the researchers of Cedars-Sinai are in the 200s or more. And I tend to sort of look at those more.
Okay. Last question, actually. Was SIFO, SIFO, more abdominal pain and gas, or was that for our candid diet? I think they're asking, you were saying that SIFO was more abdominal pain and gas and something else is for nausea. I think that was a clarification.
Yeah. So first of all, I hope you guys appreciate that term SIFO as much as I did when I learned about it, because it's just interesting to see it pop up in the conventional literature. So the nausea is more typical, according to that study, of SIFO, small intestinal fungal overgrowth, and the abdominal pain and gas is more typical of small intestinal bacterial overgrowth.
Okay, great. Thank you. So you can continue with your talk, and we can divert the rest of the questions until later, because they're mainly treatment questions.
Okay, great. Okay, so now we're going to jump into treatment. I just put in this slide because we've all made the mistake of skipping over the basics before we move into some more of these advanced treatment approaches. I highly encourage you to make sure your patient has gone through some of these basic digestive treatments before moving forward. A lot of times patients will have come into your office having already tried all this. Just make sure you know how well they've tried increasing water intake, or have they tried increasing fiber? Has it worked? Did it make things worse? Spacing meals to allow for the appropriate interdigestive cleansing wave to happen. Have they tried that? Just going through some basic dietary hygiene things. Realize that in any dysmodal patient, lactose and caffeine tend to make things worse. It's really hard to get people off caffeine. But most patients will have tried to go off dairy. Also, make sure you look at their medications closely before you jump into treatment. Okay, so I'm going to build on the treatment just by going through individual treatment modalities for SIBO, and then tie it together with some more strategy. So these are the main antibiotics used in small intestinal bacterial overgrowth. The top of the list is rifaximin, and there's 0.4% systemic absorption, so it's a gut-directed antibiotic. It's very expensive. It's not FDA approved, although it's in the application process, not FDA approved for SIBO or IBS, but we understand that potentially it's going to be approved in the next year. There's an application in. Neomycin is also used, not as effectively, but it has been used, and there's 5% systemic absorption. And those are the doses listed there that are typically used. I've seen the doses really increase quite a bit over the last 4, 5, 6 years since I've been studying this topic. And there are other antibiotics that have been used, and we'll go through those more in detail. Patients who fail using antibiotics, you'll sometimes see the mention of Vivanex, which is an elemental food formula. Another expensive treatment, but it's used in refractory or failed treatments to small intestinal bacterial overgrowth. Okay, so rifaximin is known to be active against enterococci and C. difficile. Neomycin works against many gram-negative organisms. So this particular slide points out a large meta-analysis for antibiotic therapy for SIBO. And what we do know is that with these patients overall, the average size of the sample on these studies was 60 people, and the mean treatment arms were 30. And we do know that overall antibiotics resulted in a 51% response rate. Rifaximin overall during this large review, this systemic meta-analysis, resulted in 49% breath normalization. And ciprofloxacin had the highest normalization rate on breath test of 100%. It was a smaller study, but also we'll talk about, there's potential side effects of Cipro like C. diff that may weigh into your decisions. Rifaximin, interesting enough, 1,200 milligrams per day plus 5 grams of partially hydrolyzed square gum performed the best of all the studies at an 85% breath normalization rate. And 91% of those patients reported clinical response. The problem with this systemic meta-analysis is that overall it did not really reach statistical significance for antibiotic use to treat small intestinal bacterial overgrowth. However, if you tease apart some of the individual studies, there was studies large enough on their own to stand being statistically significant for antibiotics being a treatment choice. And regardless of this, it is the standard treatment for most GI docs who are now treating standard small intestinal bacterial overgrowth. This review did not mention anything about methane producers, which is something that we now have a study that came out in this summer talking about a combination of neomycin and rifaximin to eradicate methane constipated subtypes, and I will talk about that in just a little bit. So this particular study was rifaximin in an N of 624 in the New England Journal of Medicine, looked at overall response in IBS patients using rifaximin, and it seemed to do well in overall global IBS symptoms, bloating, abdominal pain, stool consistency. Overall, it was 38% in the treatment group had a response to rifaximin versus 31% in the control, so not terribly impressive. But they seem to do better with bloating, abdominal pain, stool consistency in the rifaximin patients improved. So the most significant part of this study is that the results of this treatment lasted for 10 weeks. For any of you who have treated really difficult IBS or dysmodal patients, 10 weeks of benefits is sometimes hard to reach. So I point that out. I feel like as naturopathic physicians, we could do much better and have more to offer our patients than a treatment that doesn't control for diet and also is just an antibiotic. I think we have more holistic ways to approach this patient. And here's the study that came out for constipation predominant IBS patients who were methane positive, and a combination of neomycin at the doses listed there was better than rifaximin or neomycin. Better than neomycin alone, and we know it's better than rifaximin alone as a combination treatment. There was better improvement in constipation, straining, and bloating, but not abdominal pain. So it's not, again, not a perfect treatment and requires us to think a little bit deeper, but it's the first study that showed a way to treat methane positive with some substantial response using this combination of antibiotics. So rifaximin has a pretty low adverse effect profile and very rare at best. I do see patients, when I've used this drug, I see patients complaining of nausea and sort of the die-off effect that we know of. So I'm always prepared to help patients through that as part of my treatment recommendations. So, but it's generally pretty mild. I've had some patients where it's just very strong with more complex patients that have other comorbidities like colitis or colitis with IBS. You have to be prepared. The more complex the patient, the more that they're going to adversely react to this type of treatment.
Right. Not the house. No. Well, and I think their kids.
I'm sorry. Is there a question? Okay. So there was some feedback on the line. The emerging issues related to rifaximin is how many times can we use it without the patient developing a resistance. At this symposium, and again, one of the things about this symposium is, it is directed by Dr. Pimentel's group. He is on the board of the company that makes rifaximin. So, everything I hear, I sort of always, realize that this is one particular belief, and it's important for us to make individual decisions on what literature that we're reading and to weigh it comprehensively. But they were saying at the conference was that there's the potential of using rifaximin 3 or 4 times consecutively without developing a resistance, where that's sort of unheard of with other antibiotics. And also, neomycin does seem to generate a resistance after a couple uses. And also, they're in the process of showing that rifaximin does not kill off the colonic flora. Again, this all needs to be further substantiated, but is some of the latest commentaries by that group. And that means that it will kill off what's going on in the small intestine, but leave most of the colon flora intact. There's lots of antibiotic choices in bacterial overgrowth, and I particularly have a lot of confidence in our therapies, meaning naturopathic herbal therapies. So I'm not always using antibiotics, and I like to keep antibiotics for when patients really need them with other more life-threatening conditions than bacterial overgrowth. And that's how I explain it to patients is, not to just sort of look at this like we have this really powerful weapon in our hands, but what is the potential long-term consequence of using this over a series of time? And as you'll see, bacterial overgrowth doesn't always just go away, and that's the end of the story. So we have to be very specific about when we use these drugs. So I mentioned SIBO does reoccur, about 44% relapse rate within 9 months. Again, are we not addressing the whole picture? Why is it reoccurring? It seems to reoccur more in patients who are older aged, who have a longer-term history of PPI use and a history of appendectomy. I think earlier I mentioned the patient with acute gastroenteritis. Research has shown that the patient who has acute gastroenteritis that also has SIBO, repeated bouts of acute gastroenteritis will make this more and more difficult to treat. So secondary prevention, going back to the first part of the presentation, we talked a lot about the migrating motor complex. So this seems to me, and and this is my opinion. I haven't heard anybody else say this, so it's certainly just my opinion, and take it for what it's worth. But it seems to be that the migrating motor complex is sort of the holy grail of what we need to do to, if we were able to stabilize the migrating motor complex, we would more likely prevent reoccurrence in these patients and help them get back on track. How to do that is pretty complex. The treatments now are using prokinetic agents, such as erythromycin at low dose at bedtime once the patient's already been eradicated for bacterial overgrowth. They've seen in one study that erythromycin prevented reoccurrence by about 80 days compared to those that did not use it. So it's not great, but it does seem to be helping prevent reoccurrence, and they know it works on phase 3 migrating motor complex activity based on some of the work that they use erythromycin in gastroparesis populations. So there is a defined mechanism. So some of the other medications that they've used over time for addressing the migrating motor complex have been showing to have some adverse side effects like tardive dyskinesia. The 5-HT4 agonist was black boxed. This is degesteride, and some of the other prokinetic agents like cisapride has also been flagged for its effect of creating long QT syndrome. So some of these really targeted agents on for the migrating motor complex may have adverse effects that doesn't warrant their use. There's a few out there that are developing that I've seen that seem to have better safety profiles. The last one on those is called prucalopride. It's available in Canada now. It's had some really good safety ratings on, I believe it's in phase 3 trials now, as a 5-HT4 receptor agonist. So these are sort of biochemical targeted ways to reestablish migrating motor complex activity. And naturopathically, this is sort of an area where we're still discovering what we might be able to do to help with stabilizing this problem. So here's a few more medications that are being used in the IBS world to help these patients: secretagogues, opioid agonists. Also, as we know, low-dose tricyclic antidepressants are used quite a bit to help with visceral hypersensitivity and pain. Why do I put this on here? It's just to point out that sometimes, there needs to be sort of a bigger view at all the different mechanisms feeding into this, the patients presenting with dysmotility. Now, with an autoimmune hypothesis, we're going to probably see a lot of different therapies develop to help stabilize the migrating motor complex. So now into the area where we all focus on, and this is the naturopathic and integrative treatments. And the first thing I would want to start talking about is dietary approaches to bacterial overgrowth. There are many possibilities, and we all have our favorites, from the SCD diet to GAPS to paleo. We all have those that we feel most confident in teaching and that we've seen work clinically. I particularly latched onto the low FODMAP diet because the mechanism makes a lot of sense to me as to how, by utilizing this dietary approach, that we can reduce dysmotility and reduce some of the gas production. So what is the low FODMAP diet? This is from Monash University in Australia. This is where it was developed. It stands for low fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. So these are specific short-chain carbohydrates, for example, fructans and galactose oligosaccharides, polyols, fructose, and lactose, and they're poorly absorbed in the small intestine. Why are they poorly absorbed? Well, they seem to, we seem to lack some of the digestive enzyme processes that digest these foods rapidly. They have a low degree of polymerization, meaning instead of long chain polysaccharides, these are shorter chains, and what happens when you have shorter chain sugars in the small intestine, they're osmotically active, pulling water into the lumen, and they're rapidly fermentable. So if these, maldigested FODMAPs meet up with bacteria, you can imagine what might happen as far as fermentation is concerned. So these are some common, the categories that we focus on in the low FODMAP diet: lactose, fructose. So lactose, obviously dairy, fructose. There's various foods that are rated high in FODMAP, and the one that's high, one of the highest is apples, and the high fructose foods are determined by the fructose to glucose ratio. Galactans such as beans, fructans such as rye, and polyols such as dates. And in the back of your presentation is a whole breakdown of the various categories of FODMAPs, and I recommend this book. It's available on your Kindle to help with you walking through patients on the low FODMAP diet. I have done presentations on the low FODMAP diet that are available online, and I get deeper into this topic. But I'm going to give you some other basics. Is the reason why the FODMAP are poorly absorbed is there's a low activity of brush border enzymes such as lactase to deal with some of these carbohydrates, and the result is we see an increased osmotic load in the lumen coming from the maldigestion, which makes them rapidly fermentable and available for fermentation. And we see luminal distension when there's a FODMAP intolerance, and motility changes, bloating, pain, basically similar SIBO symptoms. So if you can imagine having giving FODMAP, high FODMAP foods to bacteria would cause further problems with bacterial overgrowth. Okay, so this particular study has some data on using the FODMAP diet compared to a traditional Australian diet, and we saw that the low FODMAP group had an overall improved gastrointestinal symptom scores on bloating, pain, and passage of wind were all reduced while these IBS patients were on the low FODMAP diet. And this is one of the only studies I know that controls for diet in this IBS population, so it's a real good roadmap. We did see diarrhea patients improve as far as stool frequency, but constipated patients did not. So still some areas of improvement and things to figure out. I'm going to skip through this slide here. There are some other applications of the low FODMAP diet. It's being used in IBD patients because of issues with malabsorption, GERD patients, and in functional bowel disorders as well. Okay, we're going to go into probiotics, and right now, as a monotherapy, probiotics have not been shown to be effective in larger studies as a monotherapy for bacterial overgrowth. However, you can see that in one study, a probiotic called Flora that had some of the common strains that we use, like lactobacilli and bifidobacterium, outperformed Flagyl from 80% to 50%. And we're still trying to figure out exactly what the role is. I know that many of you probably know and have opinions on how probiotics may help. A lot of the researchers are saying that it will help with preventing gut permeability, also reducing gas production, and potentially helping with the migrating motor complex. So this is just another study that showed that probiotics have been effective in treating conditions like colitis and IBD. I think we're just needing to catch up and look at SIBO specifically. A lot of the researchers are fairly hesitant on their opinions about using probiotics. I personally find them to be a very important part of our treatment strategy, which I'll get into in just a moment. So this was a big study that came out as we're getting into herbal therapies. It's a big study that came out recently that showed that herbal therapies were equivalent to rifaximin for the treatment of bacterial overgrowth. Very exciting. However, the study design was not so great. They used some formulas that we're very familiar with, and with companies that we all use, really well-designed antimicrobial formulas, but it was a retrospective chart review, and the doses for rifaximin was not the standard dose that we typically see used in practice. So it wasn't exactly the best one-to-one test, and there was no control for diet. It wasn't blinded, but it did prove that patients do feel better when using some of the more well-designed antimicrobial blends. And this particular study shows put some of our herbal antimicrobials like lavender, peppermint oil, also tea tree oil and thyme against some of the antibiotics that we commonly use like rifaximin and neomycin, and watched in petri dishes to demonstrate that there was significant antibacterial bacterial activity of some of these essential oils. So this is my rotation. I use 3 different blends currently. I rotate with bacterial overgrowth when I'm focusing on eradication. As we start with in a more targeted antimicrobial formula with focused on berberines and undulacinic acid, and then I try not to keep a patient on the same formula for more than 4 to 6 weeks. If I do need to repeat it, I will move on to this next blend. These are all commonly available formulas within, I can't mention any companies, but as you can see, the spectrum of the formulas increases as we go to the right. I find that these work outstanding for most of my patients. Some of my patients, just for whatever reason, believe antibiotics will work better, and I will sometimes go that route. But a lot of patients, I really encourage that we try some herbal compounds. The data is not necessarily there, but clinically, I tend to get really good responses with these 3 formulas. So just a couple other things I want to mention. Enteric-coated peppermint oil probably has the most research for this dysbiotic IBS patient. They did show that it improved the hydrogen breath test in a case report. in one study. And there's lots of randomized control studies that it's really good as an antispasmodic for pain. And this sort of summarizes, before I get into strategy, this sort of summarizes what are some of the more effective treatments to alter the intestinal microbiota. At the top, the more effective would be gut-directed antibiotics, but it's also at the same time more invasive. And you can see the FODMAP diet made this list as less invasive and also effective. So in the middle, probiotics are also shown in this study as being an effective and fairly safe way to address the microbiota. So now to strategy, and we're getting to a point where I'm probably going to have to speed up just a little bit. Strategy is really, as a naturopathic physician, holistically, this is a model that's been used in a lot of settings, the 4R model. I've adapted it a little bit to SIBO. So the therapeutic targets being first, remove bacterial overgrowth. Second, restore the gut motility and the migrating motor complex. Third, replenish deficiencies. And fourth, prevent reoccurrence. If you don't want to use that model, there is a model that's already developed through Cedars-Sinai where they're using antibiotics along with what they call a low fermentation diet, and the stepwise process using the Cedars-Sinai protocol. I've listed it here so you can go through it on your own. But basically, it's what I've been talking about using rifaximin and neomycin, or neomycin and rifaximin in combination, and getting the patient to a place where their breath test is abnormal and breath test is normal and they've clinically responded, and then also at that point putting them on low dose erythromycin, 50 milligrams at bedtime for 3 months. So back to the model that I was talking about. So we have these various steps in the process of addressing a patient to hopefully reestablishing gut health. So it's important before entering this process is to know your patient. On the left, we've all seen patients that are sort of mildly disrupted, and on the right is the riptide patient that is not doing so well and fairly sick. And we need to know where to enter with each of these patients. So lately, I've sort of developed what I call the prep phase in my treatment approaches, and this is when the patient looks more like the patient on the right, meaning they're not stable, not doing well. I may do a mild detoxification with this patient or do adrenal support and get them feeling better a little bit before going into eradication treatment. In this particular patient, I use things like the medical symptom questionnaire, MSQ, is a really good one that's put out by the Institute of Functional Medicine to help me determine how stable they are. But a lot of times it's a gut feel of how sick your patient is and if you were to push them too much by starting to eradicate. So once I've determined their readiness, we'll go into the removal phase of treatment. And in this particular process, we talked about the different herbal compounds that I use. Sometimes I will use some of the antimicrobials. And I also put the patient on removing the fermentation supply. So I use the low FODMAP diet in my patients primarily. You know, you're probably going to get very good results using SED as well as possibly paleo, the similar concepts of low residue and easier to digest approaches, things that wouldn't feed the gut bacteria. And then after that phase, I'll reassess. And I'll be getting into more detail in a second. Then we move to replenishment. At this point, I replenish the innate digestive and absorptive processes of the gut. So these are things like restoring pH balance through digestive betaine or pepsin. Digestive enzymes are important at this phase. And again, reassessing at every step of the way to make sure the patient's moving forward and staying stable. And finally, and I'll talk about this in just a second, is going to repair, which is the final stage to get the patient ready to prevent reoccurrence. And this is restoring or repairing the barrier. So the preparation phase, we talked about doing some type of light, mild cleanse. This is for the patient who is not very stable. You might do a hypoallergenic cleanse or adrenal support and determine their readiness. The metabolic screening questionnaire I use to measure and quantify how well a patient's doing. Also the digestive wellness questionnaire. It's a really good questionnaire to see how off digestively your patient is. So the remove phase, when the set begins, is usually 2 weeks to 2 months. I usually allow 4 to 6 weeks for plant-based antimicrobials, and then 2 weeks if I'm using conventional antibiotics, and I start them on the low-residue diet. Watch them and reassess either through repeat of the breath test or just clinically. And then with a clear response, I move to the next phase. With partial response, I consider repeating and switching or switching the agent. And with no response with this, I really question my diagnosis. So then we move into replenishment, which is a 2 to 4 week process. The patient's doing better. I usually do start them on prokinetic agents. I have been using the low-dose erythromycin, 50 milligrams at bedtime. Some people use other treatments like melatonin, and I've also seen 5-HTP used. I'm hearing some news about low-dose naltrexone. And then I get the patients to start the betaine HCl challenge to make sure that we're at an adequate gut pH and continue on the diet. I also get them on a digestive enzyme support and bile acid salts to help with replenishing the innate digestive process. So that's about 2 to 4 weeks, and then we reassess and then go into another phase of replenishment where I'm addressing gut immunity. I usually use immunoglobulins to help with secretory IgA levels and continue some of the stuff we've already been doing. And then I begin to replenish the microbiome at this stage. I use Saccharomyces and Lactobacillus and Bifidobacteria. I'm very careful with FOS at this stage as well. And then finally, if they're doing well, after that phase, I'll start them on repair, which is gut repair type formulas, things that we think help with gut binding, like zinc carnosine, NAG, and such as N-acetylglucosamine, aloe, althea, various things to help with cell wall integrity and gut adhesion, gut cell adhesion. And that continues for about 3 more months, and then if the patient is still on board, I'll have them come back for a challenge of the FODMAPs. A lot of times they'll push me to challenge earlier, and I do adjust based on the patient's need. But we sort of challenge the FODMAPs individually, and there's a whole process of doing that. Patty Castos has a good program about how to challenge FODMAPs individually. And then I just keep them on a prevention from that standpoint, usually just more of specific dietary approaches that we've learned through the re-challenge process. I usually have them on a gut, sort of a broad spectrum gut supplementation that sort of addresses the digestive enzymes, also addresses gut permeability, and then I have them come in to me if they're starting to see any signs of reoccurrence that last more than 3 days. Okay, so trying to figure out if we have time for case studies. And I think I'll go through the case study here and see if we have how much more time we have after that. Okay, so these are some of the cases that I've chosen. This first case was chosen because it's more of a straightforward case, but it was really a good example of a patient who was compliant, and through naturopathic approaches, he felt a whole lot better. He was a patient that had sort of a 17-year bout with IBS, and he was pretty fearful about eating, dining out, traveling, very anxious every time he went out of town because of his gut. He'd get bloating, gas, and alterating constipation and diarrhea, and had some crampy abdominal pain. On physical exam, he had the typical tenderness and guarding in his abdomen region in all quadrants. I did do a digestive wellness questionnaire, and we can talk about that more, but he showed on that he was highly dysbiotic, also had some possible low digestive enzyme function, and potentially gut permeability. We did do the breath test, and he was methane and hydrogen positive. So a clear case that he had some bacterial overgrowth. I did spend a good deal of time talking to him about meditation and various breathing exercises, and started on low FODMAP, and then on the berberine combination with betaine. And this is just an example of his lab test showing his positive results. And so he came back in 30 days, and just with the FODMAP, he reported improvement, only a few days of constipation and bloating. So we increased the dosage a little bit of the acrylic and berberine, and continued on the low FODMAP, and had him come back in 30 days. And he was having some occasional bloating at that point. He was feeling less anxious about eating. His bowel movement frequency went up to 1 to 2 days. And this is someone who's had this for about 17 years. So we were both feeling good about this at this point. So he was clearly responding to treatment, and then we started him on addressing the migrating motor complex with erythromycin at bedtime. And he really pushed me, because he was doing so well, to start challenging FODMAPs. So we challenged the polyols, and he challenged negative. He was excited about that. And then challenged the fructose, and he had diarrhea. So he was clear that, at this point, fructose was an issue. We kept that out and continued on the plan, and then we were going to challenge fructans and lactose later. I got an email from him 45 days later, still doing well. He challenged fructans fine and lactose fine, and just was going to stay off fructose and challenge galactans later. We stopped erythromycin and started repletion, had him continue digestive enzymes, and started repletion with probiotics. And he just disappeared like patients do. And 6 months later, he came back in, and I was worried, things had gone astray. But actually, he had been doing great for 6 months. He challenged galactans, and they were negative. And he just wanted to talk about prevention. And so we added a gut repair formula and just kept him off fructose and continuing probiotics. And then he came back 30 days later after doing that, and the plan is holding. He's just going to continue this plan. This was May, and come in if something flares that lasts greater than 3 days. So let's see if we have time for. Okay, so I think I'll try to get through one more case study and then leave it up to the host to let me know if they want me to continue talking about cases. So this is a very interesting case of a patient that really appeared sick when he presented in my office. He's a 43-year-old male. He came in with abdominal pain, nausea, and weight loss. He had actually lost close to 20 pounds in 3 to 4 months, and he's been flaring for 2 months. He had a history of less severe symptoms that were similar following travel, and he remembers many travel-related infections. He wasn't really eating much, only ghee, bread, and coconut butter. He had some blood work done in his PCP office. It was normal, but he was worried he had cancer. He did have a colonoscopy some time ago. He did look very sick to me, and so I did not necessarily feel comfortable moving forward with a bacterial overgrowth treatment until we did a really thorough workup. Again, general abdominal symptoms on physical exam. His white blood cells were slightly suppressed, and his neutrophils were slightly low. SED rate was slightly elevated. The cutoff usually we get concerned about arthritis and various autoimmune is 40, but again, with his weight loss and some of his GI symptoms, worried about cancer. So I did that SED rate, and then his CRP was low, so we were reassured. And some of his other autoimmune antibodies, which I ran, were negative. His pancreas seemed to be in good function, and he wasn't showing blood in his stool. So then we took a deep breath, and we moved on to some of these other treatments. And he had a combination of methane and weekly hydrogen positive on the lactose breath test, and his CDSA was positive to a few blastocystis hominis. Otherwise, the digestive function appeared to be normal. So the patient came back. I'm sorry, wrong way. So this was his breath test showing a combination, and this particular lab combines methane and hydrogen, and you could see the early spike, and then you see the later spike. So this is indicative of small intestinal bacterial overgrowth. And he was a diarrhea patient, he was a mixed diarrhea and constipation patient, which was interesting because he had both methane and hydrogen positive. And this is a slide showing the blastocystis on his CDSA. So he wanted to start off, we both agreed that starting off with a mild plant-based antimicrobial would be best. I did start him on a homemade elemental diet just to get his nutrition up. And we both felt at this particular time, I felt like the probiotic, he was not wanting to give that up. He felt anxious about that. I'm sure you've seen patients that they feel like their probiotic is all that's helping them. And so we moved to a probiotic away from the antimicrobials, and at night I actually used one of the prescription-based probiotics. And then he went through that, and I'll show you some comments in did well. And we moved to, he contacted me and wanted to move to an antibiotic protocol because he was feeling like he was strong enough to do this treatment. So we first did neomycin 500 milligrams 3 times a day, and then I wanted to address the blastocystis as well. So we did Flagyl. We factored in Flagyl into that as a co-treatment and transitioned to low FODMAP diet and continued the probiotic at bedtime. And he was actually, he wrote me back saying things seemed to be working well. His energy and appetite was up. He was eating a simple diet and having very less nausea and no cramping. His breath seemed to be getting better. His stool was sinking. So then he wrote me back after the antibiotics were completed, and he felt like his symptoms were getting better, feeling more energy, able to eat more larger quantities of food. He felt like he wasn't sure that we had addressed the entire gut, but he felt more stable. So then we moved to more replenishment at that point. I combined some immunoglobulins in his treatment, addressed his gallbladder a little bit with some bile salts, improved his betaine, his digestive enzyme process with betaine and pepsin, and he, just as an overall, he was very interested in supporting other processes, so we also supported his liver with detoxification with glutathione and branched-chain amino acids. Overall, it's just more of a holistic approach to treatment. He wrote in August, earlier last month, and he continues to do well, still some rebuilding going on, but happy with the progress. So that's more of a long-term response. I think it's interesting to see these patients definitely seemingly do better than the earlier relapse rate we see with just antibiotics and the erythromycin. So it just gives me confidence that our therapies work with these patients. Now, these are just 2 examples. I have one more case I won't have time to present, but where you can see it doesn't always go this well. It can go all different types of directions, especially with patients with multifactorial things going on, and that's a discussion for another presentation with more advanced cases. I've seen cases not work well. I've seen patients get worse, and you walk them through the getting worse phase, and they end up getting better. The sicker the patient, the more that you're going to see non-typical responses. But we all know this. This is what we do as naturopathic physicians. We handle very complicated cases. But at least today I've shown you sort of a process to take people through, a way to work them up and assess them with some knowledge, and also a process to treat and take them through to hopefully a stable gut function. We have to keep our eye on this autoimmune etiology and ebb and flow with that as we learn more about ways to further stabilize the migrating motor complex. And I'll open it up to questions and answers.
Okay, great. Dr. Rendy, thank you so much. This has been fantastic. We have a ton of questions, so
okay.
We might just go over a couple minutes just to try and get as many in as we can. So there were a number of questions about more specifics about the SIBO botanical rotation diet, the formulas, the rotation formulas, and people just want to be sure that when you send out your final presentation to the audience so they can have the updated one, that you include all of that information. There was a lot of interest in the actual treatment specifics.
Oh, okay. I wasn't aware that they already received. Yeah, so they'll get this presentation, and I wasn't sure that if I could or couldn't mention product names, so I kept those out. But I did put, the details of the formulas.
Great.
They will be in the presentation.
Beautiful. Okay, great. Thank you. And there was just one clarification regarding the SIBO rotation slide. Was do you rotate between formula A, B, and C for 4 to 6 weeks each, or just choose one formula and use that one for the 4 to 6 week remove portion of the treatment process?
So how this works, and this has been something, I used to have a go-to formula, and I found it didn't work with everybody, and lost some sense, as far as it would work partially. So then I started applying the concept of rotation, just like we see in infectious disease. And what I basically do is I start with, say, formula A. In that particular patient that we talked about, he received formula A. He responded to it, and I didn't really need to switch after 4 to 6 weeks on the treatment. He responded. So, but if that particular patient would have responded, say, 50% to treatment, he was feeling somewhat better, but we weren't necessarily at a reduction of gas or bloating, or his motility and his digestion, as far as constipation or diarrhea, hadn't changed. Abdominal pain hadn't changed much, or maybe at 50%. Then I would move to formula B, rotate that in for 4 to 6 weeks. I wouldn't necessarily question my diagnosis at that point, because the patient has responded, but maybe the formula, they're developing a resistance to it, or maybe it's not hitting the right enterococci. But it's not as sensitive to that. The enterococci are not as sensitive to that formula, so we switched over to formula B. And the same process would go based on how that patient would respond to formula B.
Okay, great. There's a couple questions about what do you do when you have a patient who is chronically constipated, you want to do the breath test, but they really don't have a bowel movement without their laxatives or supplements that they do. How do you manage that?
Yeah, I've had that actually happen in practice, and so in those particular situations, I'll often step back and see, have I done a good, thorough job working up the patient? Have I ruled out other causes of constipation? And if I'm sort of at the end of my diagnostic workup, and I've ruled out other causes, I'll go through with an empiric trial with those patients. And there is better data now on neomycin and rifaximin. I will have to say that the constipated patient is harder to treat of the two. Diarrhea patients respond really well. And so to answer the question is, in that particular patient, if the patient feels comfortable with a therapeutic trial, I will go forward with that.
So for clarification, you basically just won't do the breath test and you'll just go forward with the treatment?
Well, yeah, if they're using laxatives and we can't take them off it because they're not willing to, or potentially it could cause other problems, then we really can't do the breath test. It sort of makes it valid. Okay,
great. There was a question about using probiotics with FOS or prebiotics, and I asked for clarification so that you've mentioned them, but is there kind of a time when you use them, when you don't use them, when they're okay and not okay to use?
Yeah, so I think the concept of prebiotics I introduced at the beginning with the patient, and then as they're stable, I introduced the concept and I introduced the actual, when we're challenging FODMAPs at that stage, which is a pretty clinically stable stage, that's when I would start to try patients on FOS. I mean, I think it's wonderful to have that on board if the patient can tolerate it, but realize it's basically like giving them a high FODMAP nutraceutical. So you just have to make sure they're stable before you introduce it. So I wait until we're at the more of the repair stage. Or if the patient's been doing so well for so long and they're getting eager to kind of get on with things, sometimes I'll bump up that timeline. We all know that, you know, protocols are just protocols, and, you know, sometimes the patient guides you more than a protocol. In fact, it should guide you more than a protocol in almost all circumstances.
Okay, great. Another question, do you have any opinion about whether significant levels of blastocystis should be treated, and if so, how?
I'm sorry, can you repeat the question?
Yeah. Do you have any opinion about whether significant levels of blastocystis should be treated, and if so, how?
So significant, yes, I actually find that there is, I'd say in about 50% of the patients that I see that have blastocystis that we've tested, it's causing problems. So depending on how well the patient's doing, I've found, interesting enough, that Saccharomyces does a really good job with it. I think I learned from one of my mentors and saw some data on Saccharomyces boulardii, helping wipe out blastocystis. A lot of times I will use Flagyl for that. Neomycin also has some data for blastocystis. Depends on the patient. Herbally, if we're staying away from antibiotics, I think these formulas that I use seem to kill all kinds of archaea, bacteria, fungi. I wish I could spell out the mechanism of each, but they seem to work, and hopefully we'll learn more. I think Dr. Yarnell is going to be talking about herbs in the upcoming talk, and hopefully he'll address which ones work well on blasto. But right now, my go-to is Saccharomyces boulardii.
Okay, great. Can you repeat the name of the person who has the information about challenging FODMAPs?
Yeah, so I went to an advanced FODMAP conference by Patty Katsos, C-A-T-S-O-S. She has written, I think, a book called IBS Free. She has a wonderful PDF that's like a step-by-step guide about putting patients on the low FODMAP diet and how to take them off FODMAPs, how to challenge them back. It's got handouts in it that you can sort of plug into. It's a really good way to get started. And the Monash University, also those books, the book that they have, the third edition book, is outstanding.
Okay, great. Thank you. So a couple more questions here, and then we're going to have to wrap up. Do you differentiate how to treat methane-heavy versus hydrogen-heavy producing bacteria?
Well, from a naturopathic perspective, I treat the two the same. I will say this, until that study came out, I did usually start most of my constipation patients on neomycin because there was better data on that than anything else. There is data that rifaximin decreases methane production. So the constipated patient is, I'll tell you this, with our treatments, we confidently can get the gas, bloating, and discomfort away, but improving the frequency of bowel movements is sort of still a big question mark. Obviously with some of these cases it happened, so I've stuck with low FODMAP and these herbal compounds in both populations when I'm going from a strictly naturopathic treatment standpoint. And then I will be, when I do choose antibiotics, I'm going to start using, going to start use rifaximin and neomycin in combination, especially if there's FDA approval of rifaximin and it's more accessible to patients, because right now it costs about $800 for a round. Okay, great. So the last question is more of a comment. There's a few people that really wanted to get some more detailed product names of formulas that you use, but we can't do it over even though you're not paid
for it. We actually can't do it for the CE accreditation, but is there a way for docs to get in touch with you if they want to get some more information?
Yeah, so I'd be happy to share. The last slide, I think, has contact information. Let me just do that real quick.
Okay.
So any of these, and I'll be happy to share the products I'm using and more details about things I couldn't mention. Specifics, that's fine.
Okay, wonderful. Well, Dr. Rindy, thank you so much. We are going to wrap up our webinar for the evening.
Okay.
On behalf of the CNDA, we'd like to thank you for your participation, and we'd like to extend our sincere appreciation to Dr. Adam Rindy for this incredible, wonderful presentation on SIBO. A quick reminder, you will receive an email tomorrow later in the day, that is, by tomorrow evening, with a link to our online survey. Your CE certificate will be ready to print immediately upon completing this survey. Please note you will need to complete